Thank you very much, and thank you to the ICS for giving us the opportunity to present the findings of this data linkage study, which was part of a larger trial called Propel. And I would just like to thank my co-authors as presented here, and also acknowledge that it was funded by NIHR, part of the UK NHS. I have no affiliations to declare. The use of hospital records to provide us with data about patients has been underused in the past, and this is often due to the fact that information was poorly recorded and indeed that systems could not be linked. Within Scotland, however, we are ideally placed to undertake such studies as each patient has an individual community health number and the individual patient record sets are collected routinely and held in a central database. This allows us to follow the patients in the longer term, and you will probably agree that sometimes this is more important than the short-term outcomes, both from the patient's perspective and indeed from cost effectiveness. There are few studies which provide long-term data on the benefits or otherwise of pelvic floor muscle training for pelvic organ prolapse. The patients that we were gathering long-term data on were those that were participated in the POPI RCT, which finished recruitment in 2010. This is a multi-centred study which recruited 225 women into an intervention group and received 5 individual appointments for supervised PFMT over 14 weeks, and a control group with 222 women who received a lifestyle leaflet only. The results of the primary outcome measure demonstrated a significantly important difference in the symptoms of pelvic organ prolapse between the two groups at 12 months, as reported by the POP-SS questionnaire, with the intervention group showing greater improvement, and it was published in The Lancet in 2014. So the aim of our study for Propel was really to determine if the women that took part in this original study were less likely to receive further hospital treatment related to their pelvic floor dysfunction in the long term than women who had been in the control group and only received the lifestyle advice leaflet. The approval process was quite rigorous and took us actually longer than we thought. It took us nearly a year to get the approvals. But eventually the anonymised linked data files were made available for analysis via the National Safe Haven. Our primary outcome measure then was to look at see if there's what occurrence of any related secondary care, inpatient or outpatient, for pelvic floor dysfunction, which includes prolapse, urinary incontinence or fecal incontinence, received during the follow-up period. Our secondary outcomes there were looking at any received procedures, if they had received a pessary, and we were also looking at the time to the first pelvic floor dysfunction related secondary care event. Our methods then, the follow-up period was from the date of first randomization, i.e. September 2007, to the date of data linkage, May 2018, approximately 11 years. The dates of randomization and follow-up events were harmonised to avoid participant identification. So our population, we were able to use 11 of the centres because these were Scottish centres. We were able to look at a total of 293 participants in our analysis, 149 in the pelvic floor muscle training group and 144 in the control. Approximately 8 in the pelvic floor muscle training and 7 in the control group had unfortunately died. So our data set contained time since randomization for any outpatient attendances, day cases or inpatient episodes, with at least one diagnosis, which was diagnosis ICD-10 or procedure codes relating to pelvic floor dysfunction. And this is just how we were able to relate the codes. So there's codes for a diagnosis and codes for procedures. Our analysis then was a mixed effect logistic regression model. Our dependent variables pelvic floor dysfunction related secondary care during follow-up, received procedures or received pessary. Our independent variables, which were all measured at baseline, was the intervention group, the symptom severity, the prolapse stage, and if the woman had been considering surgery or not when they first attended. We used separate models for imputed missing covariate data and complete cases. We also used a Cox regression model. The dependent variables were the same as above, and they were stratified by preference of surgery, and women who died were included with their data censored. Our results then, these are the characteristics of the participants that were available for follow-up, and you can see that both groups were similar, and also that they were similar to the whole cohort of patients that took part in the trial. So there's no difference in age or parity, and this is true also of the continuous variables such as BMI. So we had a good cohort of patients. So our primary outcome then, which is pelvic floor dysfunction related to any secondary care event. Overall, the proportion of women with the event was 48.1%, 43.6% had been in the intervention group, and 52.8% had been in the control group. So there was a significant difference between the groups in any related secondary care, in that those that had received the pelvic floor muscle training attended less. In other words, if you were looking to look at another way, looking at the adjusted odds relation on 0.61 corresponds to a relative risk reduction of 0.80, indicating that the probability of pelvic floor dysfunction related secondary care is 20% lower in those that had received the pelvic floor muscle training than in the control group after adjustment for covariates. We are also looking at age and symptom severity as recorded by the POP-SOS and stage of prolapse were factors that really increased the likelihood of further treatment, which seems logical. Our secondary outcomes, any related procedures, 32.9% in the pelvic floor muscle training and 36.1% in the control group had some additional intervention. However, these were not significant differences. Women that really came back and had a pessary then, we also looked at these, and really were 12.8% in the pelvic floor muscle training and 16.7%. Again, although the incidence was again lower in the pelvic floor muscle training group, this was not a significant difference. Looking just at our final secondary outcome, which is really the time that patients returned to hospital for any intervention or any contact, it would seem that there was a significant hazard in favour of the pelvic floor muscle training group. In other words, pelvic floor muscle training group delayed the need for further treatment and had a 35% lower hazard rate for an event. So in summary, this data linkage study provides evidence that A, pelvic floor muscle time reduces the overall long-term risk, at least up to 11 years, of requiring hospital treatment for pelvic floor disorders over a post-intervention of 10 years. And it also extends the time for which this hospital treatment is sought. The full report is pending and will be published in NIHR. Thank you.
Bill Gibson from Edmonton. Thanks, Dorian, for a really interesting presentation. I have a bit of a two-parter. I'm sorry. Firstly, do you think people who had pelvic floor muscle therapy didn't come back because they were better or because they were disillusioned?
Well, I would hope to think because they maintained their improvement, but from this study, the data linkage, we didn't do any follow-up. It'd be lovely to go and interview patients and find that out, but we don't know.
And the second one that you won't be able to answer from your data, and I apologise in advance for that. These 10 years covered the whole Scotland mesh debacle. Do you think that had an impact on people coming back for treatment as well? There was an awful lot of media coverage about how treatment for prolapses was going to kill you.
I think a lot of the data that was collected in the earlier days didn't involve mesh. Perhaps over the last couple of years, potentially it may have. I don't know.
Paul Hodges from Australia. Just in contrast to the last comment, that was the first question by the previous person, the other way of interpreting this is that not necessarily people were disillusioned, but they may have also had greater self-efficacy. So by having participated in a program where they were taking on control of their own management, their symptoms may not have necessarily been better, but they may have required less intervention because they could self-manage. Do you have any opportunity to go back to these people and send them a questionnaire to ask a little more about this? Because that's going to be really fascinating for designing interventions.
I don't think so. Unfortunately, when we were doing the POPI study, we didn't look forward enough, so we didn't ask the patients if we could contact them later on. In some of our more recent studies, we were actually doing that, so we do have permission, but ethically, I don't think we can.
It's a tragedy.
Yeah.
It's Heidi Moser from Holland. Thank you, Doreen, for a very nice long-term study. I was just wondering, in the pelvic floor muscle training group, if you have any idea what the therapist has discussed with these ladies, because when I see a patient, I discuss operations because I get a lot of questions about it. So with this information, they might think, well, let's not go to a gynecologist, for instance.
In the POPI study, I know we did identify women that were quite keen on having surgery. So that was sort of we tried to make sure that was in both groups, but we don't actually know. I think they probably have some self-efficacy, which has been maintained. But we don't really know.
Okay, thank you very much.
Okay, thank you.
Any other question?
I can ask a question. I wonder about this, that you had 11 of the 23. Was that because of the ethical approval coming from Scotland only? So
Yeah, the other ones were in England, and
Yes.
they don't have the same system of recording the health outcomes,
No.
so we couldn't trace that. Yeah.
Okay, thank you.
So this ends our session. Thank you very much for attending.